This conference will now be recorded.
Well, welcome everybody. I'm Stephanie Schneider, and today I'm very happy to have with me Debbie Beaumentre, a nurse with Firstat or in care management. And today we're celebrating National Healthcare Decisions Day, April 14th, 2021. And Debbie and I would like to share with you a video that was put together by an organization called the Conversation Project. And we really like the video because it shows you from a realistic point of view how to go about selecting a healthcare surrogate. And it shows some of the reactions people might have when you ask them if they would be willing to take on that responsibility. So after the video, we're going to talk about the different types of medical advance directives and how to be prepared so you're not suddenly caught off guard. So enjoy the video. So I hope everybody found themselves laughing at some point watching the video. Perhaps you identified somebody in your own family or group of friends that reminded you of one of the personalities in the video that we just saw. And what Debbie and I want everybody to understand is, yes, we know it's an uncomfortable process to go through. Most people are not comfortable talking about these issues. It raises insecurities, fears about the unknown. But our one message today to everybody who's joined us or who's going to watch the recording is there are some things that we can control. So it's up to us to be positive, to take that step forward. And as the title of today's PowerPoint says, have the discussion at the kitchen table, not at the operating table when it's too late. So when is the right time to have the conversation, and who should have advance directives? Well, you'll see here we have pictures of a variety of different people representing different age groups. And the youngest person here is Selena Gomez, who some of you might recognize when she started as a child actress and then became a singer. She very young was diagnosed with lupus. in autoimmune deficiency disorder. Now, we tend to think that only people over a certain age, and I'm going to use the number 60 or 65, are the ones that really should have the conversation and do the planning. But Selena is a perfect example of why the planning needs to be done early, at a younger age. So really, everybody needs to have the conversation before they get sick, before they're diagnosed with a condition, and certainly before they have an unexpected accident. And ideally, everyone over the age of 18 should have medical advance directives. Once our children turn age 18, they are legally adults. They get to make their own medical decisions. And we as the parents will not have any access to confidential medical information because of Hipaa. So if we want to help our children, should something occur that puts them in a position where they can't make a medical choice, and if we want their life and our life to remain private and confidential and not have to go to court, then our children need to have medical advance directives too before they go off to college or even the military. When you get divorced or if you're legally separated, this is a time to reevaluate prior decisions you made about your medical advance directives. You might decide you no longer want that soon-to-be ex-spouse to make healthcare decisions for you. Well, you have to be proactive and take a step forward to cancel your prior documents, or if you did not have any prior documents, then to put documents in place. And as we can see from the variety of people on your screen, this affects everybody. It affects baby boomers, caregivers, especially because statistically we do see that many times caregivers don't take the best care of themselves because they're putting all their time and energy into the person who's ill. So we don't want a caregiver caught off guard and not having their own medical advance directives. And in my mind, and I think Debbie will agree, there is no differentiation of marital status. That should not come into play. People who are single, widowed, divorced, or married are all equally likely at some point to become incapacitated and might find themselves unable to make their own healthcare decisions. So everybody, any age, every walk of life, need medical advance directives. So let's talk a little bit about role models, people that didn't properly plan, didn't have the conversation, and why we can learn from them. So many of you might be fans of Prince, who unfortunately left us very young with a lot of talent, didn't have documents in place. We look at Glenn Campbell, who was diagnosed fairly young, in his mid to late 50s, with Alzheimer's. Without the necessary documents, these people's lives were opened up to the court system. Guardianships had to be done. And this happens because we're all human and we don't have a crystal ball that we can look into to tell us what's going to happen, when is it going to happen. We just know we have to be proactive and prepare. So let's talk a little bit about the types of medical advance directives that are available to us in Florida. So the first and probably the most important one is called a designation of healthcare surrogate. Other states may call this a healthcare power of attorney or a healthcare proxy. What they all mean is that it is a way for you to designate a trusted person in writing to speak for you, to be your medical advocate when something affects your ability to speak, to understand, to reason, and to make an informed medical decision. Now, when you're contemplating who to name as the surrogate, you don't want to surprise people. You want to start by having the conversation with them. Ask them if this is something they're comfortable doing. Are they willing to implement your decisions rather than their own? These are important questions to ask. This will help you through your process of deciding who is the best person to speak for you. And don't forget about the importance of having an alternate surrogate, or what we might call a backup. Again, there's no crystal ball that we can look into to know, will the main person you named in your document be alive? Will they be healthy? Will they be able to take on the responsibility when the time actually comes? So it's so important that when we create this management plan, that we have a plan B to fall back on. Now, you heard me mention a few minutes ago about Hipaa, and Hipaa is the medical privacy law in our country that applies no matter what state you live in. So unless you give permission to a healthcare provider to speak to or share your healthcare information with somebody else, it's not going to be accessible. So there are two ways to go about this. The first way is to have a separate document, which we call a Hipaa authorization for release of confidential information, that identifies the people you're giving permission to. The second way is that within the Florida designation of healthcare surrogate, you actually can now choose to give your surrogate the access to Hipaa information in the present, or you can choose to give it only when your doctor determines you lack the ability to make informed medical decisions. So this is great, and this is fairly new. We did not have this in Florida before the law changed. The third important medical advance directive to consider is a living will. Now, this is not to be confused with a last will and testament, which is the way we pass on our assets at death. The living will instead tells our surrogate, tells our healthcare providers, what is important to me. If I'm diagnosed with a terminal illness that's going to shorten my life expectancy, and there is no cure, there is no treatment to reverse the illness, how do I want to be treated? And it allows us to go into some fairly in-depth types of medical decisions. Those having to do with, what if I can no longer chew or swallow food safely? Do I want to be artificially fed through a tube in the stomach, or a tube in the nasal passage, or perhaps an intravenous for liquids? It allows us to deal with the issue of pain medication, of do we want hospice care to help take care of us? What do we want done should the two vital functions of the body stop? And that's breathing and heartbeat. Do we want to be resuscitated? Do we want to donate organs? All of these are important decisions to think about and put in writing so that your surrogate is not left to guess what you wanted, and they're able to ensure that any healthcare provider, whether you're in a hospital, a nursing facility, an assisted living facility, or in your own home, that your decisions are going to be implemented and respected. In Florida, we use a state-created document called a Do Not Resuscitate Order. Sometimes you might hear this referred to by its abbreviation, DNRO. A Do Not Resuscitate Order is slightly different than the living will. With the living will, our doctor has to first do tests and evaluate, do we have a terminal condition? Whereas with a Do Not Resuscitate Order, it doesn't require the finding of the terminal illness. This form allows you as the consumer to complete it and sign it, and then obtain your doctor's signature as well. If, however, the person never signed a do not resuscitate order, and now they're no longer sufficiently competent to do so, it is possible for the surrogate to sign it, or if there is a court-appointed guardian who is allowed to make medical decisions, that person may also sign the do not resuscitate order. Now, here is one of the practical differences between the living will and the do not resuscitate order. Let's say somebody is found either in their home or in a residential community, and they're on the floor unconscious, and the person who finds them immediately reacts by calling 911. And the 911 operator sends an ambulance to the location. What happens? Well, EMS is trained to look for a do not resuscitate order, which must be printed on yellow paper. It is not acceptable to be printed on white or any other color. It must be printed on yellow. If they find the do not resuscitate order, they immediately look to see, are the two signatures there? And can they find an ID to make sure that the person who signed it is the person before them? If that is the case, then they implement the do not resuscitate order. But they are not by law required to search for a living will. If they happen to find a living will, they are to bring that with the patient to the nearest emergency room. At that point, the patient is delivered into the hands of the emergency room doctor, and it will be up to that doctor after evaluation to decide, is it appropriate to implement the living will. But if EMS does not quickly locate a do not resuscitate order, then by law, they resuscitate the person, get them in the ambulance, and deliver them to the emergency room of the nearest hospital. I briefly mentioned a little while ago that a living will could also address whether a person would like to donate organs. Some people do this on their license. You can also do this in a written document where you can make very specific decisions known about whether you want to donate only certain organs. Would you like to donate, for example, tissue to be used to help burn victims? So you can be very specific also. Do you want to donate your body to science? Or if you're only donating organs, would you like your body then returned to your family, and how would you like the body prepared? So some people like to get very clear and specific in those instructions, and this gives them the opportunity to do that. This also raises another issue that many people are uncomfortable to talk about, and as a result, many people never make pre-need funeral arrangements, and they leave that up to their family or friends. For those people that are not comfortable making the arrangements, what they can do is designate in writing a trusted person to actually make and carry out the funeral arrangements. That person would then have legal authority to speak with the funeral home, to talk with a medical examiner's office, and this document should also indicate what your preference is. Is your preference to be buried? Is it to be cremated? Do you want a memorial service? Are there any specific requests you have about how you'd like to be honored after your passing? So what if we do, if none of these medical advance directives exist and now the person is not competent? Well, at that point, we have to look at what we call the measure of last resort, which is a legal guardianship. This requires us to go to court and have a guardian appointed to make medical decisions for the patient. Ideally, we want to avoid guardianship because not only is it time-consuming as well as expensive, but it also results in a loss of privacy. The medical advance directives we just talked about are private documents. They don't get recorded anywhere. They're not filed with the court. So it's a year now that we've all been living in this world that was taken upside down by COVID-19. So we have to ask ourselves the question, where does COVID-19 fit into medical advance directives? Well, we've learned that it's better to be prepared that you can become incapacitated or pass away rather than to be surprised. Many people who unfortunately were tragically affected by this virus found themselves on ventilators, intubated, where they couldn't speak. They couldn't communicate to the healthcare providers. What did they want? What didn't they want? So it's really important that if you're going to take the step after today's webinar to have medical advance directives created, you've got to tell the people that you're naming as your surrogate. You need to give them the copies. You need to give copies to all your treating physicians and your specialists. If you're going to travel, take a set of the documents with you, whether it be on paper, whether it be that you take photographs on your phone, or you have it on a thumb drive. You have to not only have the documents, but you have to share them so the people who need to know these exist. And I think, last but not least, it's the family, it's the people you love that will appreciate that you took the time to do this, to put it in writing. So nobody has to guess and then be worried, are they making the wrong decision? That creates a lot of guilt that people don't want to live with. So I wanted to share a couple of ideas, what I call best practices, for when you're ready to make decisions about your medical advance directives. And that is, you can be as detailed as you want. You can describe in your living will or advance directive different types of medical situations that might arise, and how do you want those handled if your ability to speak is compromised. I had a client who happens to be a veterinarian, and her best friend's father became a victim of a fire and had burns over 70% of his body. And as a result, in her detailed medical advance directive, she addressed the issue of what she would want done if that ever happened to her. It's also important to explore with somebody like Debbie, who's an experienced nurse, what are the possible different medical interventions that might be available? And how does that impact me physically so I can decide what my preferences are? So it's important to understand terms like CPR, intubation, what's a ventilator? Are these things I want? Are these things I don't want? Am I undecided, or would I want to indicate in my advance directive that I want these treatments tried for a while, but then if there's no improvement, I want them stopped? And it's certainly important when we go through these issues to think about what are our goals in life. And I don't mean the goals of how much money do we want to make? Do I want to get married? When do I want to retire? It's the quality of life goals. It's what does life really mean to you? Do I want my life prolonged? Do I want the healthcare professionals to attempt to cure but then reevaluate? Or is my goal to have a less invasive treatment and simply be provided with comfort care? So now it's my pleasure to introduce Deborah Beaumentre of Firstat RN Care Management. I've had the pleasure of working with Debbie and her team for probably close to 20 years now. And Debbie is going to share with us what is an aging life care manager, how do they help people through these issues, work through them, take the next step. And what are the benefits of working with an aging life care manager? So Debbie, it's my pleasure to turn the presentation over to you.
Thank you, Stephanie. Good afternoon. So the question is, what is an aging life care manager? Care managers are also known as aging life care managers or aging life care professionals. These professionals have a varied educational background which focus on issues associated with aging and disabilities. In our practice, we utilize registered nurses with the exception of one mental health specialist who is teamed with registered nurse on cases. The goals of working with an aging life care manager is to improve the quality of life for the client while bringing peace of mind to family members, a lot of whom live out of the area. This is achieved through a consultation process of the family and an in-person assessment to start the care coordination required while maintaining the client's well-being and safety. Most times when a care manager is called, the client is in crisis. The care manager will attempt to diffuse the crisis, working with a team approach, including the client, family members, healthcare providers, legal and community resources. The care manager will work at maintaining a better quality of life for the client while keeping their wishes in mind, but also looking at safety and cost containment. These options may include family mediation, support and counseling, assisting with exploration of residential communities, and navigating the healthcare system. During our assessment process, we are also looking to see if the client has advanced directives in place. We will ascertain if these directives might need to be updated, and we will make referrals to attorneys for this process. If the client does not have the advanced directives, we will start to have a talk with the client. If they are resistive to the talk and speaking about advanced directives, the care manager will, on following visits, continue to have gentle conversations regarding healthcare decisions and advanced directives. If the family members are on our Hipaa form, we will start to include the family members to have the discussion regarding advanced directives. If advanced directives are formulated, we will place a copy in a red binder, those being the healthcare surrogate, living will, and DNR, along with a copy of the client's driver's license or ID, Florida ID. And we will put this red binder on top of the refrigerator. The client will know where that is, and also if there's any caregivers in the home, they know where that is in the event of an emergency so that it can be given to emergency providers upon arrival. If the client goes to the hospital, we always request that that binder goes with them to the hospital. Next slide, Stephanie. If a client goes to the ER, we will have a care manager who is on call 24 hours a day, 7 days a week. Our copies of the advanced directives are kept on our server. Those copies are then sent over to the emergency room along with contact information. That information is provided to the ER doctors and staff. At that time, we will contact the family members or whoever is listed as the healthcare surrogate to let them know that their loved one is in the hospital. What we have found in the past, that if a person does not have documents in place, that the hospital may ask the person that is being admitted into the ER if they would like to formulate a healthcare surrogate in the ER. This is not a recommended practice at that time because usually the client may be confused, they have a lot of anxiety, they may be in pain. The person that they're picking as their healthcare surrogate may not know that they are being put into that position, and they may not know what the choices are for the patient that is being admitted. So it is not the appropriate time to be formulating the healthcare surrogate. Once a patient is being admitted to the floor, we will then follow up and provide the floor with the documents again, as we have found in the past that the documents are not being transferred from the floor to the, or from the ER to the floor, and they get lost in the shuffle of paperwork. We will then also provide the family members, healthcare surrogates, with the information of where the loved one is, and also provide the floor with the contact person of the healthcare surrogate's number. That's what care management can do and how they can help the clients.
So Debbie, I think this would be a great time in our presentation for you to share with the attendees some real life stories of what do you and your team actually see happening? What are the kinds of calls you're getting? What have you learned? What are some of the tips you can share with everybody today?
One of the things I can absolutely say is you're never too old and you're never too young to have your healthcare documents in place. A perfect example is my son has been in the military 16 years, and he gets deployed quite frequently, even now with COVID, and every year he has to update his healthcare surrogate documents and power of attorneys because of deployment. So, and he's been doing that for 16 years. So he started at a very young age at getting those documents involved. So this is something that it's never too early to start those documents, but it can be too late to start those documents. So that's very important. I could share a personal experience if you would like, Stephanie.
That would be great. Thank you, Debbie.
So approximately 15 years ago, myself and my husband did not have our healthcare documents in place. And, you know, who would have thought? And of all people, my husband was a sheriff's deputy, and of all people, he probably should have had those healthcare documents in place. We had traveled, went on a cruise, came back, and he was scheduled to go for his physical, and me being a nurse, noticed that something just was not right. So I made a call to the doctor. The doctor sent him for testing, and the MRI was laying on the table, and I picked it up and knew the answers before we went to the doctor. When we went to the doctor, the next step that we made was to the attorney to formulate his advance directives, because 3 weeks later he passed. So had those documents not been in place, I would not have been able to make decisions for what his healthcare needs were. We made funeral arrangements and everything within a matter of 48 hours. At the same time, I realized that I needed to make my own healthcare directives and also my own funeral directives, so that my children down the road would not have to be saddled with those decisions in life when the time came. Since that time, within the 15-year period, I have as well updated those documents. And it's important that you think about making those directives and also updating them. If you have them, look at them, see if the people that are on there are still able to serve in the capacity that they are, and then also, making it an and/or situation, so that in the event that one can't, the other can.
Thank you, Debbie, so much for sharing your personal experience with us today. Can you leave us with some tips? Tell us how you and your team members work with individuals and families, walking them through what to them can be a very scary conversation?
Usually we find a lot of resistancy with the elderly clients because they don't feel that, their idea is that, oh, my family knows what I want. I don't have to put it in writing. So we do have to get the family involved. And once the family gets involved, and then getting the legal team involved, we just have them, we encourage them to reach out to their attorneys and have a discussion. And we sit down and we talk to them before they go to the attorneys, and have the conversation of, if we give them an idea, if this happened, what would you want to do? We talk to them about, do you want to be buried? Do you want to be cremated? Do you want to stay here? Do you want to go north? So we have these discussions with them. And sometimes the family members are not aware of what their parents' wishes are. So it's important that we do have this discussion. And with the families being so far away, we have to have that conversation on a phone call sometimes, and include them on a conference call or a Zoom call. And sometimes it's baby steps because there's a lot of resistancy with having this discussion.
Thank you, Debbie. Great advice. Appreciate what you've shared with everybody today. So there are some tips Debbie and I do want to share with everybody, because our hope and our goal today is that this motivates you to take the next step forward and be the role model for other people. So we're suggesting that the first place to start with is make a list. You saw it in the video. The person had made a list of different friends, family members, coworkers, neighbors. Make that list. Then start the dialogue. Talk to the person, tell them what's important to you, and see how they respond. The best thing you can hope for is to have an open, honest dialogue. And at the very least, even if one person says, I'm honored that you asked me, but I'm not comfortable, that's a good thing. That allows you to cross that person off the list and go to the next one. So that by the time you do make the appointment at the attorney's office, like Debbie talked about, you've got a focus. You've actually talked to these people, and the lawyer can confidently prepare the documents knowing that the people being named in the document are willing to accept the responsibility. I'm an oldest child in my family, and I will tell you, in working with clients for 30 years now, how many people actually think naming the eldest child, whether it's for medical decision making or financial decision making, is the right thing to do. And it really isn't. You want to match the person's personality and their approach to life with the medical decisions you want made. And that may not always mean it's the oldest child. It might mean it's the youngest child or the middle, or perhaps you're going to name two people together to be surrogates. And because we are living in a world of technology, you don't have to limit who you name as your surrogate because of where they live. So geography really doesn't pose any kind of barrier. It's, will the person do what needs to be done whenever they're called upon, whether that's getting on a phone call, maybe a video call with a doctor, or getting on a plane. Our second tip is, please don't try to do this yourself. We know that there's a lot of things available on the internet today, but there's also a lot of problems that they bring. And you're not going to have a document or something on the computer talk back with you, have a conversation, ask you questions about your family dynamics, get you to think of things that you didn't know to ask. So have it done the right way the first time. And our closing tip is, please don't wait until you're going into the hospital or you're already sick or you've just received a diagnosis. As Debbie mentioned, those can be times when people feel very overwhelmed. They're not thinking clearly, and you might not be hearing 100% of what's being explained to you. It's better to go through this process when you are clear-minded and when you can take the time to digest and make the best informed decision for you. So in closing, I'd like to share with everybody that Debbie and I are going to partner again on May 5th to kick off National Elder Law Month in May 2021. And we're going to host a panel discussion at 12:30 that day. And it's called Lessons from the Front Line, Experiences Shared by Elder Care Experts. And we're all going to be talking about different life-changing situations we encountered, what we learned from them, as well as important things that we want to share with you to make it easier and better should you find yourselves in a situation where you're a caregiver for a loved one. So at this point, I'd like to open it up, excuse me, to any questions. You're welcome to unmute your microphone, or if you prefer, you can write a question in the chat box. It's in your upper right-hand corner. It looks like a speech bubble from the comic strips in the newspaper. Well, if there are no questions, we'd like to thank you for joining us today. Please feel free to reach out to us. Okay, I see. Thank you, Claudia and Indy. We're glad that you found this information today really important. And, please, as I said, reach out to Debbie, reach out to me. We're here to support people and guide them through this process. And if there's somebody you're thinking who could really benefit from today's webinar, the recording will be posted both on my website as well as YouTube channel within about 48 hours. So please feel free to share it with your colleagues, your family members, people you know at church or your synagogue, and help everybody to become informed and get their medical advance directives in place. Thank you for joining us. We hope you stay healthy and well.